This is Selvarajah,
Natasha Malone,
and Sherrelle Pendley.
Welcome to our presentation, which is based on the response of oral sulfonylurea to permanent neonatal diabetes mellitus. The purpose of this paper is to show the successful transfer from insulin to oral sulfonylurea, which are hypoglycemic drugs and are used for people with diabetes. These drugs are used to lower blood glucose levels. This was performed on a 3-year-old girl who was diagnosed with permanent neonatal diabetes mellitus. It is a rare disease found in 1 in 500,000 newborns. It was found that neonates seem to have intrauterine, which is glucose in the urine, polyuria, failure to thrive, and ketoacidosis, which all display within the first 6 months of life. The administration of insulin could result in a dramatic improvement in growth, and it could present in 2 forms of permanent neonatal diabetes mellitus and transient neonatal diabetes mellitus.
Permanent neonatal diabetes mellitus is a rare form of diabetes which is caused by a mutation in the KCNJ11 gene. The R201H mutation in the KCNJ11 gene, which is the gene that encodes for the KIR 6.2 subunit of potassium channel of the pancreatic beta cell, has occurred due to it being damaged and the base pair being replaced with another. The coding has changed and affected the whole chromosome. This is what leads to the gene being mutated and the disease being present. Potassium inwardly rectified channel, subfamily J member 11, also known as the KCNJ11, is the gene that is responsible for making the subunits of the ATP-sensitive potassium channel. The potassium ATP channel consists of 8 subunits, 4 from the KCNJ11 gene and 4 from another gene. The potassium ATP channels are found in the beta cells, which are the cells that secrete the hormone insulin. Mutations in the KCNJ11 are the common cause of permanent neonatal diabetes mellitus. On the slide you can see that the gene is located where the yellow arrow is.
Shown here is the DNA sequence analysis of the patient. The patient was a 3-year-old female. As you can see from the data shown on the slide, the mutation has occurred at the base pairs and G has been replaced with A. You can also see the location where this has occurred. The little girl was born at 40 weeks, weighing 4.4 pounds. She was born to a healthy mother with no history of diabetes. She was admitted to the hospital at the age of 50 days old with an acute illness. She presented with fever, vomiting and diarrhea and was found to have hypoglycemia. Her blood glucose levels was above 20 millimolars. She had no clinical or biochemical evidence of ketoacidosis. Her hypoglycemia was persistent and she was started on a subcutaneous insulin isophane. She was also diagnosed as having a de novo heterozygous mutation in the KCNJ11 gene and was transferred from subcutaneous insulin to oral bleckenlamide, which is an anti-diabetic drug. It works by increasing insulin binding and sensitivity at receptor sites, by stimulating insulin release from the beta cells in the pancreas, and also reducing blood glucose levels. At the age of 2 years old, the little girl was transferred and there were several blood glucose readings taken before, whilst and being administered the oral sulfonylurea. There was a dramatic improvement in the blood glucose levels after the oral sulfonylurea was administered.
The data recorded before the transfer was HbA1c to have 10.7%. Fasting blood glucose was 5.6 millimolars per litre. The 2-hour post-oral glucose tolerance test glucose was 2.1 millimolars per litre. Her blood glucose was monitored for 4 to 6 times per day. The results of the recorded data showed glucose in a range of 15 to 18.6 millimolar per litre, insulin at 150 picomoles per litre, and C-peptide, which was less than 0.5 ng per milliliter.
24 weeks from starting glibenclamide, she continued to show improvement. Capillary blood glucose monitoring continued at home showed that it was almost within the normal range, and the HbA1c dropped to 5.9%. The patient was compliant with the medications. She was weaned off insulin 8 days after starting glibenclamide, and blood glucose monitoring was continued. Preprandial glucose was in the range of 3.6 to 8.2 millimoles per litre. Midnight monitoring of the glucose was in a range of 3.6 to 10.8 millimolars per litre. 8 weeks later, while still on glibenclamide, with no episodes of hypoglycemia or diarrhea, capillary blood glucose was in a range of 5.5 millimolars per litre to 8 millimolars per litre. HbA1c decreased from 10.7 to 7.1%, and the insulin level was 19 picomolars per litre.
So to conclude, it has been shown that the mutations within the KCNJ11 gene cause permanent neonatal diabetes mellitus. Pearson et al. Showed the successful switch from insulin to oral sulfonylurea in 90% of patients with the KCNJ11 mutation. This is the first case of a successful switch from insulin to oral sulfonylurea in a patient with the R2O1H mutation.
Thanks for listening.